This program, you're actually charging a fee, I was noticing, and I was surprised that you're actually able to do that on an online program.
Yes, sir. Yes, sir. So it's a Dr. Pankaj sir's initiative. We realize
Acha.
we realize that
Online, Dr. Neeraj, we are online.
Okay.
We can start.
Okay.
So, sir, what is happening is okay, sir. We can start the class, Dr. Pankaj.
Yeah,
sir?
Yes,
yeah.
you can. Yes, you can start.
Good morning, all the delegates, dear faculty members, dear speakers, coordinators of this program. Welcome you to the fourth e-masterclass on pediatric cardiology. IAP Delhi has been in forefront of these academic activity. As we were just discussing, we are doing it for last 3 years now. We had e-master classes in various specialties. We have done it in the field of pediatric hematology, rheumatology, endocrinology, neonatology. And Dr. Krishna sir, we started this program so much so that in neonatology, we got 800 registrations. And as you are correct, that these are all paid registrations, and this is all over India. So this year, this is our second program of pediatric cardiology. We just finished pediatric rheumatology. So we are not even a single Sunday is free from e-master class at IEP Delhi. And Dr. Nandish was there as a chairperson even in pediatric rheumatology. So he can vouch for whatever our commitment is to the academic activity which we are conducting all over the country and throughout the year. So with these words, I welcome you all. It's my proud privilege that such a senior person, Dr. Krishna Kumar, who's said the doyen of pediatric cardiology is here, and so is Dr. Raja Joshi, the doyen of pediatric cardiac surgery and neonatal cardiac surgeries. So he's also there. So I request Dr. Neeraj Agarwal to please start the proceeding, introduce the speakers, chairpersons, and then the proceeding. Over to Dr. Neeraj, because it's his mind, Dr. Neeraj, Dr. Mridul, they have been doing this session every Sunday. So even the program designing was done by Dr. Neeraj and Dr. Mridul. Over to Dr. Neeraj, please.
So, good morning, everyone, and it's my privilege to introduce Dr. Kishan Kumar sir. Yesterday I was thinking who will chair sir, and then we could not find a senior person who can match his energy and his understanding. So we thought, let us introduce Dr. Joshi sir, who is the pediatric cardiac surgeon and possibly can understand and compete with him. So Dr. Kishan Kumar sir is the head of department of pediatric cardiology at Amrita and Kochi. He's a ex-Amsonian DMP cardio from AIMS, and he has a fellowship in pediatric cardiology, Children's Hospital, Boston. He has established a program of this AIMS coaching and wonderful program. They have started DM cardiology now, DM pediatric cardiology also, first in India. So nothing, no words for to describe what he has achieved till now. Publications maybe around 250, 300, sir. He has completed 300 publications now. He has Sitaram Jaipuri Award for Excellence in Medicine and Healthcare 2022. He is the International Fellow of American Heart Association. He has been the President of PCSI India. He has edited multiple books. Whatever article comes to our mind, we try to read who has published earlier, and sir's name comes up. That Dr. Kishan Kumar sir has published something on each topic, and wonderfully he has crafted this pediatric cardiology branch in India. Thank you, sir, for accepting this our initiative. We are proud to have you. We are honored to have you, sir, here. Then we have chairpersons our Dr. Nandish sir. Nandish sir is our currently he's EB member of IAP National of IAP. He has special interest in emergency pediatric medicines. I have heard a lot about him that he is good in emergency pediatric medicine. That's why we thought it's an emergency subject here. So we thought he should be our chairperson here. That's why we involved him. We welcome sir to you with folded hands. Thank you to join us, sir. Dr. Joshi sir is our pediatric cardiac surgeon. Those who are in NCR would know him, and those who are in South also would know him. He is one of the best pediatric cardiac surgeons. For years, he has established the Department of Pediatric Cardiology in Gangaram, and a lot of students have been trained by him. Currently, he runs a program of training of pediatric cardiac intensive care also in Gangaram. So we welcome Dr. Joshi sir here, and we would look for your input, sir. Thank you for joining us, sir, today. Thank you, sir. Dr. Pankaj, over to you, Dr. Pankaj, sir, for the further proceedings.
So I request Dr. Nandish sir to say a few words on this program and his involvement and the initiative which IIP Delhi has taken in this field.
Yes.
Over to Dr. Nadesh, sir.
Yes. Thank you. Thank you, Dr. Pankaj, sir. Very good morning to all the esteemed speaker, panelists, and the delegates attending today's session. It's my honor and privilege to be with you all today in this fantastic endeavor to deliver academics to pediatricians. IIP Delhi, as we know, is a forefront leader in delivering academics with all the latest evaluations, diagnostic methods, management methods, and it's doing very fantastically and well appreciated by all the members. So today's session is also a very important session to enrich the knowledge about duct-dependent lesions. Our esteemed speaker, Dr. Krishna Kumar sir, is present here to enrich all of us about the evaluation and management of duct dependence. I thank you for inviting me to chair this session, prestigious session. I wish all the best and successful for all your endeavors together. Yes.
Thank you, Dr. Nadesh. So over to Dr. Raja Joshi for a few words on this topic and our initiative, sir. And
thank you, Dr. Pankaj, IIP Delhi, and this initiative is great. I think the onus of sharing the knowledge that as pediatric cardiac specialists we have gathered over the years in our country, the onus is on us to share this experience and confidence that we have in what we can do about these very sick patients, sharing it with our pediatric colleagues, and that is how this branch will probably go to the next level. And I think I can probably imagine of no better speaker than Dr. Krishna Kumar, who can voice this opinion and get that impression across. Thank you for having me, and thank you for inviting Dr. KK. He is like one of the best in this field who can throw light on this subject. Thanks.
So thank you, Dr. Joshi, and now it's over to Dr. Krishna Kumar. All of us are really looking forward for a fantastic lecture on this issue of ductal dependent lesions. So over to Dr. Krishna Kumar, sir. You can start sharing your screen, sir.
Thank you so much. Of course, I think it's a great initiative. Neeraj, congratulations. And of course, congratulations to IIP Delhi also for having really put together something that is a very good way of doing it. Out of experience, I'll tell you that of course, I agree completely with Dr. Raja Joshi that it is imperative that we share our knowledge across the entire pediatric fraternity, because pediatric cardiology has developed in the last 20 years, and many pediatricians have not had the opportunity to watch or understand pediatric heart disease, modern way it's managed, because during the training years, it wasn't there. So this is an incredibly important responsibility that we have. Speaking from experience in Kerala, I have to tell you that I must have organized something to the tune of 300 odd CMEs and workshops in the region. And that has brought about a transformation. Transformation in awareness, transformation in outcomes, and transformation in timing of referral. And another thing is that we are a team. Pediatricians, all of us together have to work together to ensure that the babies have the best possible outcomes. We should not be working in silos where we are, in our own ivory towers, and pediatricians have to sort of refer the patient, and we don't have to work with that kind of an approach. So with that, I also want to tell you that I've been doing something similar for cardiology in general. I've been running the masterclass in cardiology for the last 3 years. Across the country, and mainly for DM students in cardiology. And it's been a wonderfully successful and deeply gratifying experience. So I think please do continue with this, even though it's a lot of effort. Sundays go, you hear from families, all those things are there, but somehow the pain is worthwhile. So with that, I will actually start this program. This talk, and I was told by Neeraj that we'll be having some kind of an interactive process. So for that reason, I've put in some questions, MCQs, inside the process during the course of the presentation, just to stimulate the minds. But Neeraj and Raja, please don't hesitate to stop me, and of course the other chairpersons also, please don't hesitate to stop me and ask questions whenever you feel you need clarifications, or whenever you think that I should slow down and explain things a little more carefully.
Yes, sir. Thank you.
You're able to see my slides, I presume.
Yes,
Yes,
sir.
sir. Yes,
Very
sir.
well, sir. Very well. Thank you.
Okay, with this, I'll just start off by definitions. And I think this is important to understand what are we going to talk about today. Two entities, duct-dependent pulmonary circulation and duct-dependent systemic circulation. Now, it's important to recognize that we allow ourselves a little leeway. So pulmonary blood flow for pulmonary circulation, duct-dependent pulmonary circulation, pulmonary blood flows entirely or almost entirely. So there is that little caveat because there is a little gray zone there. And I will explain that, which is supplied by the PDA. Same thing for the systemic circulation. Part or whole of the systemic circulation is supplied by the PDA. And you will understand as I take the examples. Okay. So this is the essence of what we are talking about today. So in duct-dependent pulmonary circulation, we have pulmonary atresia. It's very obvious. You don't have any forward flow into the pulmonary arteries. So those patients either with intact ventricular septum or VSD or pulmonary atresia in the context of any congenital heart disease is a duct-dependent pulmonary circulation. Critical pulmonary stenosis. So there is almost pulmonary atresia, but slightly different because you can manage this differently. That's also a duct-dependent pulmonary circulation. There's a unique entity called physiologic pulmonary atresia where the pulmonary valve is there, but the right ventricle is not able to eject blood into the pulmonary artery because the tricuspid valve is severely leaky, either from Epstein's or some other cause. That also is a form of duct-dependent pulmonary circulation. Duct-dependent systemic circulation, the best example is hypoplastic left heart, but there are other examples. Aortic atresia, that means you have well-developed chamber, but there is no aortic valve. Or critical aortic stenosis, that's near atresia. So that's also a sort of a relatively duct-dependent situation. Interrupted aortic arch, where the lower half of the body is dependent on the duct, or critical coarct, which is almost like interrupted arch from physiologic terms. So these are the two situations we are talking about today, and they're very different because we have to approach them differently. The only thing common is that they require the PDA, and they can be both rescued with prostaglandin. So I will take duct-dependent systemic circulation first in my description, but before that, I want to share some important data. So we did, so in Kerala, because there is a very good government scheme now that allows every newborn to be screened and referred through a process called Hridayam. It's a very remarkable program that has been there in Kerala for the last 10 years, almost 10 years. Now, when Hridayam was started, we decided to do a registry of 47 hospitals in Kerala. This was an initiative from Sri Chitra. Dr. Deepa Shashikumar took it on, but I sort of guided her. And what we decided is that we will take every single newborn with heart disease and put it into a registry. We'll get the whole data on demographics, diagnosis, antenatal, postnatal screening, how was it identified, how was it transported, how much they had to travel, what happened to those babies, and finally, how many survived. So in the period of 1 year, we connected 1,474 newborns. So that will tell you how many newborns are actually dying in various parts of the country. Because if you start looking for them, you have a lot of them. And we had identified 418 with critical CHD. So I wrote the paper that we wrote was on critical CHD outcomes from Southern India. This is a very significant registry. It was published in Archives of Diseases of Child last year. So patient profile. So we had patients with all four common conditions that we talk about in newborn heart disease. duct-dependent pulmonary circulation, systemic circulation, TGA, and TAPVC. Now, duct-dependent pulmonary circulation was the overwhelming majority. It is interesting because of the newborn screening, almost everybody was picked up very quickly. The average age at diagnosis was 2 days for most of these conditions. And that is amazing because of the newborn screening. And of course, they all had slightly low birth weight, and a reasonable proportion had an antenatal diagnosis, because part of the Hridayam program, we do have an extensive antenatal screening as well. Now, very interesting, in this, we had these patients, every single baby was referred, they were transported and they required ventilation. I'm going to come about the issue of PGE1 again, because there was this tremendous reluctance to transport them on prostaglandin, which is part of the mental block that exists in the collective pediatrician mindset, which we have to overcome. Saturation at referral was in the 80s. On arrival, it was slightly lower in DTPC. And then they all had to travel an approximate distance of 80 kilometers for being referred. Then, interestingly, they underwent 22 of the duct-dependent pulmonary circulation underwent surgery, 47 underwent duct interventions, which is either a ductal stenting or a PDA or a balloon pulmonary valvotomy. And reasonable survival was seen in duct-dependent pulmonary circulation. And across the board, actually, we had a reasonably good survival of all these newborns after everything, surgery. And these are actually numbers comparable to the West almost, because you have so many issues in these newborns. So 5 to 10% was the mortality rate. But one category was very bad, that is duct-dependent systemic circulation. And I have to talk to you about that. There, the mortality was horrible. In part, it was because we did not offer treatment for hypoplastic left heart, but it also was because a lot of patients had serious damage before they were referred. And I'll talk to you about that. You can see that the mean age at surgery was fairly high for duct-dependent systemic circulation. So this is very important data, because this is data from Indian context, from Kerala, and tells you the story of what happens in the community, not so much as to what happens after the patients come to the referral hospital. And so this data is of great importance to the pediatrician community. With this background, I'm going to then talk to you about duct-dependent systemic circulation first, because that's the most worrisome category. Here, babies are dying, and babies can be saved. So let's look at this category. So here, I'm going to ask you a question. And this is a question that I want everybody to think about. We can talk about the answer as we go along, but I'm going to slow down and tell you, okay, what is the desirable size of PDA in duct-dependent systemic circulation? Because there's a very fundamental difference between this and pulmonary circulation. Because you are trying to provide the entire blood flow to the body or lower half of the body with this duct. Okay, and sorry, go ahead.
I don't know the exact answer, but I presume more the merrier. I don't know the
Correct. Absolutely right. Absolutely right. So we want a very large duct in this. This is absolutely right, and you got it right. Because systemic circulation has a high vascular resistance. Now, if you want to perfuse the systemic circulation, you need a big tube. You can't do it with a small connection. So that's the correct answer. So, for example, I'm going to ask a couple of other questions so that we get the concepts right. It's very important. Now, this is for the pediatricians. In a patient with VSD and interrupted arch, that means there is no blood flow to the lower half of the body. That is flowing through the PDA. The lower limb saturation is 85%. Now, this is a very important concept, and I will come to it once again. The PDA shunt direction is left to right in systole and diastole. Left to right in diastole, right to left in systole. Both directions in systole and diastole, and D, it is determined by the size of the duct. Now, it's a concept that I want you to understand because it will help you answer the next question. So I'll give you a minute or so to think about this. So you'll get the answer very soon, but essentially you have to understand that the flow across the PDA is determined by the relative resistances of the two circuits. The pulmonary circuit has very low resistance as compared to the systemic circuit. So in a PDA, in a typical patient, even if the arch is interrupted, during diastole, blood has to flow back from systemic circulation to pulmonary circulation. At that time, heart is not pumping, but the flow is going to be dictated by relative resistances of the two circuits. And because pulmonary vascular resistance is always much, much lower than systemic vascular resistance, even when the arch is interrupted, blood flow will reverse in the PD. It's a very important concept. Very, very important concept, because this is at the essence of how you should take care of these babies. So as a corollary to the previous question, I want you to answer. I want all of you to guess here. What is a good saturation, acceptable saturation in a newborn with prostaglandin, with, let's say, hypoplastic left heart? The entire circulation in the systemic circulation is dependent on prostaglandin. Here, what is a good saturation?
70%.
70 is low. It's not bad. It's better than 92 and 98. The answer is 83 of the four that I have chosen, but 70 is not a bad answer. 70 is a better answer than 92 and 98. Our instinct as pediatricians is to chase the saturation. You always like to see saturation in the 90s. So you tend to oxygenate these babies vigorously. That is very, very dangerous in duct-dependent systemic circulation. And in my opinion, apart from the fact that prostaglandin is not used, the second biggest killer is overuse of oxygen. When you overuse oxygen, you reduce pulmonary vascular resistance and you steal away blood from the systemic circulation. As a result, you result in extensive organ hypoperfusion. So, a newborn is being transported on prostaglandin with duct-dependent systemic circulation. What will be your FiO2? You are forced to give mechanical ventilation because baby had apnea. Now you're put the patient on ventilator. Now you have to decide FiO2 as a pediatrician. तो आप बताइए कौन सा FiO2 चॉइस ठीक रहेगा आपके लिए?
Option D.
No. So that is the typical response that most pediatricians would have. It's an instinct, hardwired instinct that you have got because 90% of your problem is pulmonary disease. 99%, I would say, is when you have to deal with a child with bad lungs. So then you're forced to ventilate and you try to target a good saturation. But here it does damage. Here you should only transport on room air. Even if your saturation is 80, that is perfectly okay. But when you transport a duct-dependent circulation, even pulmonary circulation, it is reasonable to use room air, but in systemic circulation in particular, you have to be giving room air. Now, this is something that is not taught. It's very important for you to recognize because it does a lot of damage. Not only is it a concept that is necessary for transport and stabilization, but it's a concept that is necessary for us cardiologists when we manage these babies. So essentially, these are prototypes of duct-dependent circulation. One is hypoplastic left heart. That means left ventricle is small, mitral valve is stenotic, aortic valve is either atretic or stenotic, ascending aorta is small, HLHS. Now you see, pulmonary saturation in the pulmonary vein is 98% because the lungs are working well. Your saturation, venous return, upper half has 55, lower half has 70. Typical RVOT saturation, right ventricle pulmonary artery saturation is 85, which is a mixed venous saturation because little bit of blood comes from here, all of them mix and produce an 85% saturation. That then goes into the systemic circulation. This is the ideal sort of situation. 83, 85%, you have a nice situation. Now you want to make this 98, you have to increase the pulmonary blood flow too much and steal the blood away from systemic circulation. Here is an example of interrupted aortic arch. Here, only lower half is dependent on the DPDA. So you have the same set of numbers, but upper half will have 98 lower half will have 85, and upper half should have 98. So this is an example of duct-dependent systemic circulation, but it's not the entire circulation, only the lower half of the body. And you will have differential cyanosis in this situation. So these are two classic examples that we tend to deal with. But the second example is more important than the first. In India, we tend to not treat HLHS very much, but this is eminently salvageable. Okay, so here is important concepts. PDA needs to be, so I'm summarizing all those 4 MCQs. You need to have a large PDA. First question that we talked about. Second, you need to not have too low a pulmonary vascular resistance because it will steal blood from the aorta. A good saturation is at the cost of tissue perfusion. I'll tell you a simple rule. Blue blood is better than no blood. Very important rule in duct-dependent systemic circulation. Children tolerate hypoxia reasonably well. Newborns, their fetus में तो इतना ही होता है. So when they are born also, they are reasonably well tolerating. If their lungs are okay, they don't get into trouble. So you don't have to chase the saturation. But if they are high, yes, go ahead.
Sorry, I'm trying to interrupt. A lot of PGs ask us the question, when you're targeting saturations, are you talking about upper limb saturations or lower limb saturations?
So upper limb, both limb saturations in HLHS, lower limb saturations in interrupted arch.
Yes. So
whenever you have differential cyanosis, it's the lower limb that you target.
Yes. Thank you, sir.
Yeah. So, important rule. Remember that bottom line, blue blood is better than no blood. That applies to almost every situation in life. So, a newborn with hypoxia is far better off than the newborn with hypoperfusion because end organs get messed up with hypoperfusion. But end organs are very resilient in the face of hypoxia. You'll see if you have a child who has a resting saturation of 65-70%, your lactate doesn't go up very much. But if you have a child with a hypotension or hypoperfusion, lactate starts to rise very rapidly. So that's a very important concept. So here is an example of a patient who had a hybrid procedure for hypoplastic left heart in our institution, where we put a stent across the PDA. And the reason to show you this is to show you how large this stent is. It's a giant stent, isn't it? We would never be able to do this. We should never do this when it's a duct-dependent systemic circulation. But because we are having to perfuse the lower half of the body with the PDA, we are forced to put this super large, this was a 7 or 8 mm stent that we had to put to allow for good perfusion to the lower limb. And what is very important to understand is when the blood is injected into the aorta, you see it going back into the PA. That is the natural tendency because of reduced pulmonary vascular resistance. So here's a case example. Let's do it through the case example. Real life example. Hundreds exist in my institution, but this is iconic. Second born child, G2P2, L1, Taluk Hospital. That means in Kerala, I would say even below the level of a district hospital. Okay, 3.2 kg. Nice. Baby was good. Cried immediately after birth. Antenatal scans were unfortunately reported as normal. There was no substrate for early onset sepsis. Child was sent home, day 2. This was before the Hridayam program. This doesn't generally happen nowadays. Child went home, nothing, told everything is fine. And I think to my best memory, the mother underwent sterilization. Now here is what happened. Day 3, poor feeding. Shown to a pediatrician, no specific treatment, reassured. Day 4, drowsy, difficulty in breathing, seizures. Admitted to a private hospital, circulatory collapse, ventilated, started on multiple ionotropes. Transported to our hospital to the NICU because it was thought to be sepsis. Accompanied by a neonatologist in an ambulance, ventilated, lots of events during transport, hypoglycemia, frequent hypotension. Child arrived on day 6, edematous, pale, dusky, mottled, cool peripheries. Ventilated quite nicely, FiO2 was 80%, SpO2 was 90%. And BP in the right upper limb was 72/31. right lower limb, because we got involved, was actually not very well recorded. Now, this should have raised a red flag, but it did not. Very meticulously, the person who was transporting has noted reasonable brachial pulses, but has not been able to feel the other pulses. No murmur audible on the auscultation. Arrival labs are like this. These are it doesn't have a terribly, yes, CRP, some elevation, but not a terribly high, some thrombocytopenia. Blood urea was 143, creatinine 2.1, enzymes, liver enzymes off the roof, INR 4, potassium really high, and lactate of 6.7 with acidosis. Preliminary working diagnosis still, despite all this, sepsis, because sepsis is your dominant problem. We were called at some point, but essentially this is the story. Then echo was done. We were called because I think the neonatologist really paid attention to the discrepant pulses, and we found it's VSD with interrupted heart. Of course, we had to start prostaglandin. The duct was shutting down. Inotropes and antibiotics were continued. Mechanical ventilation was continued, but we brought down the FiO2 to room air and kept the ventilation setting modest, accepted PCO2 even 45, 50 sometimes. Okay, because that will elevate the PVR, pulmonary vascular resistance, and allow better perfusion. Prostaglandin, of course, it's life-saving. And we started with a high dose to open it up as quickly as possible, and then brought it down to 0.05. Okay. And of course, in the next 4, this is a long story because the child came with so much end organ injury, we couldn't send off the patient to surgery. We had to wait. In the meantime, CRP went sky high. Child was, of course, vulnerable to sepsis with all these end organ injury. Everything settled over a period of time. So eventually, this is 2016, prior to Hridayam.
Okay.
Go ahead. Questions? Anything, Neeraj?
Continue. I think you can carry on.
Yeah. So surgery was performed on day 18 in this extremely compromised child. We had to wait for 12 days because of all what had happened. We did a VSD with arch repair, but the child also struggled post-operatively because of all the pre-operative insult, including sepsis. 10 days of ventilation was needed, 14 days ICU stay, and then finally child made it. Even then, so it was a long haul for the child. So, it's a real, the story is a very powerful story because it's duct-dependent systemic circulation is often missed and mislabeled as sepsis. I don't blame you guys because your overwhelming problem is sepsis. Neonatologists and all of us doctors are taught to think of common things first. So if you are a trainee in neonatology in a peripheral hospital, or you're working in a relatively basic setup, you start talking about heart disease, you are going to have problems with a large number of patients. So it's important to accept the fact that sepsis is the most important factor, but there are some red flags. Most important is to at least do a pulse oximeter screening at that time. Look at upper limb and lower limb. And if lower limb is very poorly perfused, you won't get a very good trace, but if it is well perfused, you will see a reduction in saturation, especially if it is interrupted arch. Or even if it is hypoplastic left heart, you will find a reduction in saturation across all 4 limbs. It's not a very striking reduction, but it will never be more than 95%. For that period, do not ventilate the child with high FiO2. Keep the child on room air and look at the saturation upper and lower limb. Obtain an echo at low threshold. Nowadays, access to echo has improved vastly, and I am really in favor of point-of-care ultrasound by neonatologists, at least to pick up these conditions, something that I think should be our mission in the next 5 years. As you get familiar with ultrasound for the rest of the organs, the heart should not be an exception, and you should be able to pick up basic heart disease. Start prostaglandin early, transport on room air, and early surgery after end organ recovery. Sometimes, if you don't have end organ recovery, don't wait. But injury, if you have end organ injury, wait for the end organs to recover. I'll stop here and I will take comments from Dr. Raja Joshi because I think his opinion on timing of surgery, how do you handle it, is very important.
Very, very well presented, and very important issue that you have brought up is and the Hridayam program, the conclusions that you showed us was actually an eye opener for me also, that there are actually patients who can be picked up and we are not making the honest effort. And I must congratulate you and the whole Hridayam team that you are able to do that. You picked up duct dependent systemic circulation for a very right reason, because I think they are very, very important to pick up at the earliest. The whole sequence that you described, I want to just sum it up in one words. Just try to balance the circulation. The QP means the pulmonary blood flow, and the QS means the systemic blood flow. You have to balance it out. And the goals for that balance are your saturation is the easiest for you to pick up because you don't have invasive lines till then. Saturation is a very important goal during transport, during stabilization. Another thing that is in a critically sick child, when the child is very critically sick, you should up your ante to think about a cardiac problem. Septic children are also sick, but in nothing is working. So to bring up the cardiac, on the top of the list, or at least second in the differential diagnosis, is what I think Dr. Krishna Kumar is trying to hint here, is that we need to start talking cardiac. We need to start at least thinking about it and train our brain before we can actually get the evidence. If we start training our brain, we start thinking about it, then we'll obviously look at the evidence, try to seek for echo, try to have low threshold for prostaglandin infusion. I don't think prostaglandin in a critically sick ventilated child is of any loss. If you have a cardiac lesion which is duct dependent, even sometimes without echo, you can go ahead and start prostaglandin. There's a dramatic effect. You can always switch it off. So I think these are very important things. And once you are diagnosed, surgery is completely dependent on stability of the child. If the child is coming with a pH of 7.1, just day before yesterday in our ICU, I think Neeraj will share that same experience. We had a child who came with TGA. In today's day and age, a TGA is coming to us with 7.1 pH. It is very difficult to salvage quickly. Surgically, it is very difficult to get onto to the operating room with that kind of unstable child. And with that hypoxia, TGA is a different lesion. I know I'm giving the wrong example in the sequence of events. But say, for example, if it was a critical aortic stenosis and the pH is 7.1, LV is dysfunctional, not because of the obstruction, but also because of the pH. Transmigration of bacteria in the gut is happening. And then next, for sure, there will be a blood culture which will come out positive. That is taking me farther and farther from the child. Me means taking the surgeon farther and farther from the child. From getting a safe, quick surgery done with safe, quick recovery period. So the point here being highlighted by the speaker is that quick pickup leads to not just diagnosis coming up quick, it leads to everybody's job getting easier and the child getting back to recovery faster. I think that's what my take on this situation is, sir. So
actually, this is exactly what I wanted to tell you, because sometimes you just get after the surgeons. Why is he not operating? Well, the results are terrible if you operate when your patient is acidotic, urea is sky high, kidney is bad, liver is bad, INR is 4. You just can't operate. You have to wait for the child to recover. So that's the big challenge that you have in that patient. Okay, let's go on.
I have two questions.
I want to ask.
Please go ahead.
Here.
Please go ahead. Yeah, please, happy to answer.
So the same baby which you highlighted, a ductal dependent lesion, initially came with suspicion of sepsis, but cultures were probably negative. And later on, you said that probably he got some infection also.
Correct, he did. That happens, as Dr. Raja Joshi said.
It happens, right. So if a baby got blood culture positive infection and also has a ductal dependent lesion, but is not in multi-organ failure, so should the surgeon be operating, or he wait for some antibiotics to go on, culture to become negative, and then operate?
Absolutely. and Raja Joshi will agree with me. You operate during culture positivity, you have terrible results.
So you wait for the culture to become negative and only then go.
Correct. Absolutely. You give a period of cover for antibiotics. Sometimes we have a good clinical recovery. Patient looks much better. We obtain a culture, and we have seen the CRP has come down. Everything has come down. Sometimes you may be constrained to move faster, like in an obstructed TAPVC. You can make an exception that you give appropriate antibiotics for at least 48 to 72 hours, and you can go in. But ideally, you should ensure that the child is not septic.
Now, sir, the two more important questions here. One thing you said that about focus. Dr. Pankaj is with us also. And, I am a proponent of focus also, sir. But in the last classes, lot of speakers and chairpersons have said that this can lead to overdiagnosis and misdiagnosis. So there are issues with the focus. And though we are promoting it in our unit also, our neurologists do the focus program. Even PSU team is also doing it. But lot of pediatric cardiologists have an issue with this, that half knowledge may kill the child. So, sir,
I don't agree. I don't agree because I'll talk to you from experience. I did a survey. It was 2010. I published a paper, and I will share that paper with you. The whole concept of newborn screening took birth in India at that time. I had to do 6,000 echoes in every single live born baby in a peripheral hospital to validate pulse oximetry. I trained 2 pediatricians, and they needed 1 month training. And then they did those 6,000 echoes. In that 6,000 echoes, there were 2 errors. Both the errors were actually committed by pediatric cardiologists. The pediatricians did not make any mistake. So with correct training, it's possible for a pediatrician to exclude. So you should not mystify echo. You can pick up fundamental lesions, but it needs training. I'm not saying do focus without training. But the way we are, if we try to become extremely protective towards, okay, only we should be doing echoes and make it very complex and regulation driven, then we will be having the vast majority of babies in our country will have, we will be missing their heart disease. So I think it needs a balanced approach. Of course, you should not be doing half-baked, frivolous echoes, but you need to actually train and then do.
Dr. Saurabh is there in the panelist. If he can unmute, with your permission, sir, Dr. Saurabh sir is there. And I don't know if he's can unmute himself and throw some light on this topic, which we feel very strongly about. Dr. Saurabh sir? I think he is...
you can go ahead, I think, in the interest of time here.
Okay, sir.
Yeah,
okay.
I'll go ahead.
Sure.
Okay, now we'll talk about duct-dependent pulmonary circulation because this we need to quickly go through. I guess I have about 15 minutes, 10, 15 minutes. So, okay, state the true response. And it's good to make these questions they make you think. What is true of the 4? I'll read it out. A newborn with pulmonary atresia with intense cyanosis is likely to have a continuous murmur, which is audible. B, screening with pulse oximeter has a high chance of identifying duct-dependent pulmonary circulation. C, it is mandatory to obtain an echo before starting Prostat. D, the chest X-ray can help rule out transposition in a newborn. So anybody can take a shot at it.
I would take A and B, sir.
I will take A and B. Yeah.
So A is the wrong answer. This important concept, all of you have to get. Once you have blueness of that level, you have no murmurs. This has been not adequately taught anywhere. Because if you have to hear a murmur, you must be able to get enough blood going into the lungs. Therefore, if a baby presents with pulmonary atresia and intense cyanosis, you don't get murmurs. In fact, it's very interesting. When we open up the duct, they're happy when you hear the murmur because it means the blood is flowing into the lungs. So, important concept, murmurs are likely not to be heard easily in newborns because the quantum of blood flow required to produce a murmur is very little, is very significant. So, newborns have very little blood flow. The cardiac output is very little. The quantum of pulmonary blood flow is very little, so you don't hear murmurs very well. The aortic regurgitation murmur seldom heard in a newborn, even if it is significant. Same reason, you hardly hear a murmur of a newborn who has pulmonary atresia. So the answer is B only. And I threw in A just because I needed to put this concept through and across. Okay, it's very important. B, if you do pulse oximetry, you're unlikely to miss duct-dependent pulmonary circulation because these guys, the children are bluer. Okay, I'll quickly do the C is because that Raja Joshi was very correct in alluding to it. You don't have to wait for an echo before starting Prosta. If you have strong suspicion, start it. You'll save lives. X-ray is fairly useless. Only 30% of transposition have classic egg on side appearance. Okay, so now quickly here.
Dr. Krishna Kumar, sorry, just a point that I wanted to highlight. Point number A is quite similar to not hearing a murmur in a spelling child of
Correct.
petrology.
Exactly.
Almost the same simile.
Absolutely. And newborn, there's one additional problem. In newborn, the amount of blood is very little. So you don't hear murmurs. That's why murmurs are very, very limited value in screening newborn heart disease. That is something that everybody has to now understand. Murmurs will tell you, okay, there is a possibility, but most sinister newborn heart diseases, transposition, duct-dependent pulmonary circulation, hypoplastic left heart, have no murmurs. You don't hear any murmur. Very important to know that. Okay. Here's the physiology, the numbers. I told you the same numbers I'm choosing. Okay. And slightly lower saturation, 80% in all these, in the systemic, in the aorta, in the descending aorta, in the pulmonary artery, also it's 80% because that's the only source. The duct is the only source. There's no forward flow. Okay. So this is an important diagram to understand. So essentially, PDA need not be large. Here's a very fundamental difference between duct-dependent systemic and pulmonary circulation. Because the PDA is feeding low resistance circuit, 2 to 4 mm PDA is okay. Actually, 4 is large. 2 mm, 2 to 3 mm is in fact fantastic. And your duct will supply enough and you get decent saturation. Very important to understand. Whereas duct-dependent pulmonary systemic circulation, you need a really fat duct, as I showed you earlier. Okay? A low PVR from the steals blood only if the duct is large. So you don't have to worry too much about low PVR, but it doesn't mean you give too much oxygen. You can give oxygen, but you're not so worried here. Okay? And very high saturation. Suppose you get 95, 98% saturation in pulmonary atresia, that's not good news. That means your duct is really, really large and you can get into trouble. So here's a 7-day-old, central cyanosis, 75%. Intense cyanosis while crying, no murmurs. Again, point to be noted. No murmurs when you have 75% saturation. Okay, so this is the appearance. In the again, recognize that visual diagnosis of cyanosis, we have passed that era. We have to get pulse ox these days. Child was thought to be blue for respiratory reasons, got ventilated. Okay, possibilities. Obviously, it is intensely cyanotic baby. There are 3 possibilities: transposition, duct-dependent pulmonary circulation, obstructed TAPVC. These are 3 possibilities that are dominant possibilities. There are a few other possibilities, but these 3 are the most important possibilities. Okay, and they look very similar when they come to you. So here is what the X-ray looks like. If you have the time to get an X-ray, blue blood, black lungs. So it's a very important combination. When you have these black lungs and you have a blue blood and your baby blue child, you have to start Prosta. Don't wait. Don't wait for echo here. When you get this X-ray and you have a resting saturation of 75%, just start Prosta. You won't do any harm in this patient. The theoretical possibility of missing TAPVC is very small. 99% you'll save a life. So you will open up the duct. You can see the pulmonary arteries are really small, and you can open up the duct with Prosta and start taking care of the patient. So the question of what should you do next has been answered by me because I'm trying to move on. You start on Prosta, this particular child. Child was mechanically ventilated. Often it is done because people are worried about apnea during Prosta administration. But there are ways, and I'll tell you about that. So this is something we are doing nowadays a lot, which is to stent the duct. And so this is something we can do at short notice. And that has been been a game changer of sorts in patients with duct-dependent pulmonary circulation. Important to do it technically really well. So you have to do it like a BT shunt. You shouldn't let your stent sit in the pulmonary arteries. You should just stent the duct alone, and it becomes exactly like a BT shunt, and the surgeon then is able to do the next stage very easily. So here's another example of a BT shunt, of a PDA stent, and this is a very long one because here the PDAs are rising from the innominate, and you can see the length of the duct that needs to be stented. Again, you notice that we've been very careful in putting the stent just into the bifurcation, not sticking deep into the pulmonary artery. It's very important to do it correctly like this. Okay, so this is a paper that I would encourage some of you to read. We've written it from our institution, not from the point of view, a lot of it is technique, but the important thing is that we have a lot of data here. So we have got 193 patients with newborns with ductal stenting that we published. But the point that I'm trying to make is that with the advent of ductal stenting, we have been reducing the number of BT shunts in newborns. Now, of course, Dr. Raja Joshi should comment here, but what our institutional, it has been because of the pressure on the surgical program, newborn BT shunt occupies a lot of time in the ICU, and doing a PDA stent has really helped move things forward and allow children to leave the ICU early. So our surgeons have been happy to allow us to do a PDA stenting early to enable them to move things along in the ICU and have a high turnover. I'll stop for a second and have Dr. Raja Joshi comment on the two procedures.
I think the scope of this talk is beyond this sort of even. This is a topic of a proper debate, but anyway, I think I'll take the POCUS example here. A well-trained POCUS guy will not miss the diagnosis. So I think a person who knows what is the right way of doing a stunt and what is the potential problem that can trouble the surgeon permanently. I mean, surgeon or the patient permanently by various different things that can go wrong. Even a millimeter or two jutting of the stent into the LP orifice gets jailed, things like that. I'm not saying that BT shunt has very low problem rates, but BT shunt has been a time-tested thing, and it is something that we can't just give away. There will be situations where BT shunts are the only thing that you can do. So
fully agree with you. Yeah, I fully agree with you. We still continue to do shunts in situations where the duct anatomy is not good. But the one point I wanted to make when you go through this paper is the size of this shunt, is the stent. So this particular stent you see is about 3 to 4 millimeters, 3.5 millimeters. Now, different from the duct-dependent systemic circulation where we put a 7 or 8 mm stent. It's very important to recognize that. Now, I would quickly go on to prostaglandin and then we will stop. Prostaglandin essentially is underutilized, horribly. And that's the case with Kerala also. Nobody wants to give it. For some reason, I'm not sure why. Pediatricians are so reluctant, such a mental block. It's quite surprising, despite knowing everything about it. So this was numbers that are embarrassing. And we've made some improvement, but Prosta use has been, it's a life-saving drug, but I don't know why people are reluctant. So I want to dispel some of those notions. It needs to be there in every unit which takes care of newborns. It's not justified to have the reluctance. The complications are very much manageable. They are dose-related. And it can be started for intensely cyanotic babies without a precise diagnosis. You don't need an echo. So you should do it. We start typically at 0.05, and increase if the effect is not seen, but more often you open it up with 0.05 and then you can just reduce it down to 0.02 or even 0.01 after the desired response is obtained. It's not difficult to give it. It should be given with an infusion, ideally, because then you can regulate it nicely. So you can prepare it in this fashion that I have written out here. And it's essentially really a life-saving drug. And I would leave this message as the important parting message of this particular talk. So to conclude, neonatal heart disease continues to contribute very significantly to mortality, and duct-dependent circulation is very important. It needs to be approached individually and collectively. All of us, the entire fraternity, pediatricians, all of us have to come together to try and improve the outcomes of these babies. Newborn screening, transport systems are very important. Duct-dependent systemic circulation is often missed and mislabeled as sepsis. Oxygen, ventilation, prostaglandin. Correct usage is very, very important. Thank you.
Yes. So, sir, we can take a question also. There is a question.
Yes. Yes.
By the audience. If the PDA is large in pulmonary atresia, what
Yeah.
should be done to prevent decrease in SVR? Systemic circulation, basically.
Actually, you can decrease the systemic vascular resistance by drugs that reduce afterload, like milrinone. You can give milrinone, and that is something which we give very often. You also, at the same time, try to not allow for too much fall in pulmonary vascular resistance. And the way to do it is not to ventilate with room air, to ventilate in settings where the PCO2 is kept above 40. And very interesting, we can even hypoventilate these patients. If babies are breathing spontaneously, what we have done in patients who are over circulating is to just put a hood over their face, so their PCO2 rises. And that allows the PVR to rise and keeps the systemic circulation going. It's very helpful in patients with duct-dependent systemic circulation.
Yes, sir. So normally for the pediatrician, what we do in our unit, we tell them target is 80% saturation. If you maintain 80% saturation, your QPRQ is balanced, you are safe. So that may be a broad guideline for all the.
I would give a little range, and leeway 80 to 85 is okay, because sometimes it's very hard.
Yes, sir. Yes, sir. Thank you. Dr. Joshi sir, any comments? Dr. Pankaj sir, any comments and questions?
So I want to ask the same question which I heard. Dr. Krishnan, you mentioned that ductal dependent systemic circulation who is being transported, and you keep the saturation 21%. So this is you started on Prostin also. Yeah.
So FiO2 is 21%.
FiO2, sorry. FiO2. Ductal dependent systemic circulation on Prostin during transport, keep FiO2 21%. So I still want to understand the logic behind this. So this is irrespective of the upper limb saturation going anyway, or you are only targeting lower limb saturation when you are saying so?
Yeah, upper limb, so it depends on the nature of duct-dependent systemic circulation. So if you are talking about interrupted aortic arch, you are interested in the lower limb saturation, because upper limb saturation will be normal.
Right. So that
you are interested in lower limb.
Right. If the upper limb saturation is low, then in any case you have to increase the FiO2.
Correct. Now there it's a different story. So I'm talking about, then you assess the lungs. If the lungs are healthy, then in that particular situation, your saturation target, if your lungs are healthy, then you can easily use room air to ventilate the patient, because then you're only targeting 80-85% saturation in the postductal region.
So we can mention that in that type of scenario, that we are looking for a post-ductal or lower limb saturation should not worry about. Upper limb still you have to worry, because then it's not dependent on the duct.
So that is only in patients with coarctation and interrupted arch. You understand? There are two categories. One category is hypoplastic left heart. In hypoplastic left heart, the whole circulation is postductal.
Poor. Yeah.
So there it is 85, upper limb, lower limb doesn't matter. But in interrupted arch, you have to be conscious of the lower limb saturation.
Right. And as a pediatrician neonatologist, we were told that initially that TAPVC may be a relative contraindication of starting Prostin. Now we understand, you told us that the black lung, blue baby, there is no harm, because black lung will not be with TAPVC. It will always be the white type of lung. So it can be a clear-cut message to all more pediatric and neonatologic colleagues that if you both things are correct, black lung and blue baby, then there is no harm starting Prostin anyways. Is that correct, sir?
Absolutely right. And here is where I want to just emphasize that if you have a reasonable ultrasound skill, you can rule out, you can pick up these things, TAPVC, pulmonary atresia. You can pick up these gross things and start Prostin. You don't have to get to the very fine details of the diagnosis, but you can pick up
So I'm saying
the
before
important
echo.
things. Before
Yeah,
echo.
I'm saying
Yeah,
even before echo.
even before echo, blue blood, black lungs, definitely you should start Prosta. For TA-PVC, you will have typically you have a whiteout or you have a hazy lung because of
Obstructed, yeah.
obstruction. If it's non-obstructed, prostaglandin will do no harm.
Correct. So I think Dr. Nandish, you want to say something, sir?
Oh, excellent presentation, sir. Thanks to Dr. KRISHNA Kumar, sir, for detailed the inputs given regarding the DUCT epidemiology. So, as you said, sir, it is still disheartening to know why PGE1 is not yet used at the pace which it is needed. So maybe it is more and more education is needed among the pediatricians to overcome any inhibitions. So this talk has definitely carried a very good message, sir. Thank you very much, sir.
Thank you.
One of the reasons why Prostin is not being stored by pediatricians, even in Delhi, I have seen this. They say it's an expensive drug, and if you
Correct.
keep it, it may not be used, and it goes waste. So it has. I have known examples in which I had to get Prostin transported to another center within Delhi itself. That they don't have Prostin, we keep it as stock because we have a cardiac center, so it's not an issue. So we transported. They started Prostin, and then subsequently we transported the baby to our center. So even in centers in Delhi, don't keep Prostin in their stock because they feel it may be a waste of money.
I have a solution for that. I have a solution for these expensive drugs that are seldom used. So what we do is we keep clusters of units that are located. You create a small little network and you have a hub and spoke system where one unit keeps a certain drug. Okay. You may have 5 or 6 rare drugs that are seldom used, and you make an agreement between yourselves that, okay, one of us will keep this drug, other one. So whenever there is a requirement, we'll be willing to, share. So that kind of an arrangement may have to be made for prostate.
Correct. They are practical solutions. Correct.
Yes.
So we have one more panelist, Dr. Saurabh is there. If he has some
Yeah,
comment.
I very much would like to listen to Saurabh if he has had the opportunity to listen to the talk.
Yes, sir.
Saurabh, hiya.
Yes, sir. Good morning, sir. Good morning, everyone. I mean, I could not hear completely, sir, but whatever I could hear was absolutely great. And I think the message is very clear that there are few things which sir has emphasized and re-emphasized, and I think Neeraj and Dr. Raja Joshi has again emphasized that we need more people to understand that these diseases don't follow a specific pattern, and whatever have been taught to us during our undergraduation and most of our MD, those rules doesn't follow. So we have to use more sensitive methods to pick these diseases, and we have to take more action because nowadays, even when the patients are diagnosed, they are not treated in time and they come in very bad shape, and that is determining their outcomes. Only that much I can suggest, sir. Rest everything important has been discussed, sir.
Thank you. Thank you. There's one little question I saw about milrinone, and the question was milrinone will reduce the pulmonary vascular pressure, pulmonary artery pressure. Actually, milrinone should not be looked upon as a pulmonary vasodilator. That's a complete misconception. Milrinone acts almost entirely on the systemic circulation, has minimal effects on the pulmonary circulation. So, all practical purpose, it is systemic vasodilator.
Yes, sir. A lot of units are using milrinone as a management for PPHN also. And what we say in our group also that this may not be a great thing to use. So possibly we have better drugs for the PPHN also rather than milrinone. So Dr. Pankaj sir, you are muted,
It's
sir.
my present duty to conclude the session. I have one specific request for Dr. Krishna Kumar, if it is possible. He made such good MCQs on this topic. I'm sure he must be doing it on regular basis. That is why his points are so crisp and clear cut. So if you can make some more for us, which we can keep it in our group,
Yeah.
And at the end of these 12 sessions, we can ask the delegates to answer those, just to have a post session exercise at the end of all the 12 sessions. If you
Yes,
can
we'll do
help us
that.
in doing that, it will be a good exercise for all the delegates, as well as many of us who are more on neonatologists and pediatricians, and not really into depth of pediatric cardiology. So that is one request. And now another request, I have Dr. Dinesh Goyal, who is the joint secretary and actually active secretary of IIP Delhi this time. So I request him to present a vote of thanks and say a few words on this session.
Thank you, Dr. Pankaj sir. Good morning to everyone. I'm sorry I joined a little late, but it was a wonderful deliberation. I learned all conclusion in the last, and definitely for a general pediatrician or in neonatologist, the initial part of you managing the child with the tongue-dependent lesions are very important for life saving. And I thanks today's speaker, Dr. KRISHNA Kumar sir, and our gratitude from on the behalf of Delhi IIP office. And we will look more such sessions with you, sir. And thanks for our chairpersons, Dr. Nandesh sir and Dr. Raja Joshi sir. Dr. Raja Joshi is very famous, for everyone knows him very well. And so from the IIP Delhi office, I must say thanks to everyone and all delegates too also. And every session is a very learning session, and it's very important for our daily to daily practices. And thank you so much.
Okay, so thank Dr. Neeraj, Dr. Mridul for making this program successful, and they are there all the time. So maybe next time also we'll see Dr. Neeraj and Dr. Mridul doing the show. And what is the session, Dr. Neeraj, next time? Next session is?
Sorry, sir, I'm not able to hear you. What are you saying? Sorry.
He's asking the next session
Next topic of
Neeraj.
next session.
Oh, I have to check, sir. I am not sure because some sequence changes happened, so I have to cross check and confirm. I will update.
Okay. Sure, no problem. So we'll see you next time again, all the delegates. And please, Dr. KRISHNA Kumar sir, if it is possible, please join other sessions also, because
Yes.
I thought your presence will make a lot of difference to the understanding of all the topics, not only today's topic. So next time again, 9 o'clock, next Sunday, that is 8th June, we see you all there. And from that's all from IIP Delhi. Thank you so much. Thank you, everybody.
Thank you.
Thank you.
All right.